This week on the BackTable podcast.
We do not have a functional assay for pain. Your pain is real. I know you feel it. I know it's there, but I can't feel it. I can't prove it. I can't, even see why. And then in the same breath, I say, I'm going to get a testicular ultrasound. It's going to be completely normal. In 9 years of getting testicular ultrasounds, I've never found any pathology, but that's what we're going to do. We're going to get that picture if it hasn't already been done. But that's just to rule out pathology and do due diligence. You have to understand that most of your patients come to you with this idea of like the Star Trek tricorder that I can just magically wave over their body and deduce what is causing their chronic pain. So we start each visit with, I don't know why you have chronic pain. I don't know why it started. I am not going to be able to figure that out. And furthermore, I might not even be able to fix it.
I'm George Koch from The Ohio State University, and I'm really excited to introduce Dr. Susan MacDonald from Penn State today to discuss the new AUA guideline on the diagnosis and management of chronic male pelvic pain, which includes chronic prostatitis, chronic pelvic pain syndrome, and chronic scrotal content pain. It's a mouthful. Dr. MacDonald, thank you so much for joining us today. I really appreciate it.
Thank you for having me, and I completely agree. It is a mouthful. I struggle to get through it every time.
Yeah. Do they, in the meetings, did they make you say it every time? Like every time you guys referred to the guideline, did you have to go through the whole thing?
We would say CPPS, or chronic orchalgia, just for brevity.
Gotcha. Yeah, I love that. So can you start off by just telling us a little bit about your path to reconstructive urology?
Sure. So I'm not sure what to tell you about myself except to say I'm probably slightly eccentric. I did my medical school at University of Florida. I'm one of the few actually native Floridians, multiple generations back. And then after that, I went on to urologic residency in the Bronx because I wanted to be on the front lines of healthcare. And boy, it sure was. And that was Montefiore Medical Center. And then we didn't have a reconstructive urologist at that time. I actually came to it, I thought I wanted to be a pediatric urologist, and I found myself feeling incredibly mentally unstable when I went to clinic one day and I hated it, and I went to the OR the next day and I absolutely loved it. And I thought, what is wrong with me? And then I realized I loved hypospadias and all of the flaps and stuff. I did not like bladder bowel dysfunction and asking tiny people who couldn't answer questions about that, which is ironic because come full circle, now I ask about bladder bowel dysfunction all of the time. But okay, so that got me into reconstructive urology. Then, I chose Hershey Medical Center to work because I wanted to own a hobby farm. So I am daytime surgeon, nighttime hobby farmer.
Oh, awesome. What's on your hobby farm?
What isn't on my hobby farm? So, no, seriously, people ask me that. I'm not kidding. I have spreadsheets for what I grow every year. It's intense. I order from 4 companies. I am trying to get a field of flowers going, like dahlias, like Instagram worthy. And then I also have a raised bed garden that's the size of a ranch house, and I grow a ton of things. So just as an example, I grew 24 varietals of tomatoes last year. Just tomatoes.
Oh, wow.
Yeah, I'm not kidding.
Yeah, that is. I have one raised bed, which is about the size of, I don't know, like a standard chair. And I grow one varietal of tomato.
Every little bit counts.
What it is.
If you want me to mail you some amazing seeds, I do that for people. So you tell me.
That would be great. That'd be great. My wife would definitely love that. We eat the tomatoes that we grow, just not many of them.
Trust me, I can up your high yield quantity with minimal effort. I am all about Darwinian gardening. Only the strong survive.
Well, that's probably the best answer that I've got to that question before. I would love to hear more about kind of your interest in chronic pelvic pain. I know you've said that you take care of chronic orchalgia. How you got involved with that disease process, because I'm a lover of Fournier's gangrene, and I think that my interest in that disease process baffles people sometimes. I think that chronic orchalgia probably falls under that category for most. So tell me a little bit about how you got involved treating chronic pelvic pain.
You're correct. It does baffle people, but it does kind of make you MVP in your department, though. Pro tip to the residents, if you like something that no one else likes to do, it will make you tremendously saleable to your department as a whole. Like, people love that I say, sure, send me your orchalgia patients. How did it start? So I would like to start with I didn't learn anything at all about it in residency. And that's not to impugn Montefiore. It just wasn't talked about in the early 2000s at all. And then I went to fellowship, and that was where I first learned about like pelvic floor dysfunction and how it caused chronic orcalgia and why. And also the viewpoint I approached it from was, these were young men in their 20s to 40s who were coming in who had not just chronic orcalgia, but they were coming to see a reconstructive specialist because they thought they had a stricture. They were sent for voiding dysfunction. So that's how I encountered them. And when I went out into practice, the exact same thing happened to me. So I show a Venn diagram in the lectures I give on this. And what happened was, I learned to do a denervation in fellowship, and I saw how it really helped people. So I said to my practice, not publicly, mind you, that's the death of your practice, but quietly to my practice, I said, sure, I'll take all of your chronic orcalgia. So that's like one facet. And I said, I'll take voiding dysfunction because I'm looking to capture stricture patients. And I'll take sexual dysfunction because I want, Peyronie's, implants, all that stuff. And the Venn diagram of those three things, the center, who has, and I know you know where I'm going with this, who has chronic orcalgia, sexual dysfunction, and voiding complaints, and they're in their 20s to 40s as a man, it's pelvic floor dysfunction, 100%. It's young men with pelvic floor dysfunction, and they have all of those symptoms. And so then I spent my first 5 years in practice seeing it repetitively. And it was like my entire practice was gaslighting me. I thought I was crazy. I could not understand why I kept seeing patient after patient with pelvic floor dysfunction. And yet there was so little literature about it. I went back and read the entire CPPS chapter, and there was one sentence about pelvic floor dysfunction. And I really didn't know. So I just kept reading and doing a deep dive. And then I realized this was really something I could build my career on. And the other thing that made me double down on it was, if you ever take a patient who has had pain for years, like years, 5, 10 years, and they have seen countless providers. I mean, and to them, they don't differentiate whether it's a nurse practitioner in an urgent care or whether it is a really good internal medicine doctor, a urologist, a pain specialist. They don't differentiate, but they've seen countless providers. And then you do something, whatever that something is, that takes away their pain. Those are the people that cry and hug you. And man, talk about gratifying. That is what medicine is about.
Yeah, absolutely. It's a similar, I think, story to some of our buried penis patients who never find a urologist who treats that. And they'll tell you that they've seen 15 people. They've had this problem for 10 years. Everyone says they need to lose weight or whatever. And then they come to you and you're like, oh, well, you actually have a named disease process with things that we can do to fix it. And I have the same kind of reaction from folks. It's like those are the patients who end up with happy tears.
Yeah, it's tremendously gratifying.
Yeah. How did you get the word out? How did you go from, someone who liked seeing that patient population, found a lot of fulfillment in it, to kind of getting hooked up with the AUA and joining the guideline committee?
Intentionally. That's what I would say for residents listening, very intentionally and sort of accidentally also. So I didn't know how to get there. As with all people starting something new, I could see in my mind where I wanted to be and what I wanted to do, and I didn't know how to get plugged in. So the first person is obviously you go to your chairman if you're faculty. If you're a resident, you should go to your program director or your mentor. And I said, okay, I've read all these manuscripts. I've done the deep dive on PubMed, and there's this map. It's a multidisciplinary committee of people. And I was like, I keep seeing these names. There's these 10 people out there doing amazing research. I said, how do I become one of these people? And thankfully, Mike Ponteri is at Temple, and he's in, our Mid-Atlantic section of the AUA. And so Robin said, oh, I know Mike Ponteri really well. We see each other all the time, and we've done some research together. I'll hook you up with him. So Mike became a mentor to me, and we started talking about this, and he is one of the kindest, most extraordinary people you will meet, in addition to being a wonderful physician. And he took me under his wing, and we were starting to write a grant to do some research together. And then at that point, I was really learning more and more from him about pelvic floor dysfunction as I was like learning chronic orcalgia in tandem. And the call went out, the open call for guidelines panelists. And I heard from Ben Breyer, who's a reconstructive urologist and the chair at UCSF, that he was going to be on the panel because he serves on the guidelines committee, and one person from the guidelines committee has to be on each guidelines committee. So he was already dubbed to be there. And I said, "Oh, do you know anything about this? I'm really interested in being on this." And he said, I'm outing myself, but I feel like it's important to show residents how it's done. So the world is going to laugh at me, but here's how it happened. He said, "Henry's running it." And he said it at a buffet. And in my mind, I went, okay, Henry's running it. And the second thought I had was, who's Henry? So I went back to my chairman and told him the same information I had gathered. And he said, "Oh, it must be Henry Lai. We know each other from," and it was residency or whatever. Yeah. So, of course, Henry Lai is now the chair of research for the entire AUA, and deservedly so, and was very well published in the field of CPPS and IC. And so, thankfully, Jay Rahman wrote a note to Henry Lai on my behalf saying, "Susan MacDonald is the Mother Teresa of our department who sees all of our chronic pain. You should really consider her." And I had published some, and I think Dr. Ponteri's co-chair, and so he had been my mentor and had looked over some of my publications. You know, there's only so many people who will review these publications. So he was familiar with my work. And and then I wrote a very convincing, application to the guidelines panel, I guess.
Mm-hmm. Yeah, I mean, I love the story. The urologic community is so small. You go to the annual meeting every year and it seems so huge and so vast. And then you walk around and you just keep seeing all of your friends and the people that you know. And I feel like seeing those people and thinking about collaboration is just so exciting every year. And I feel like kind of what you're describing is just the embodiment of that. It's just, like a small community that has a bunch of small communities, and you're in this community that feels really passionately about this disease process, and to be able to kind of connect with everyone, I love that story. And I also love the kind of how the sausage is made for residents and fellows to know that if you want to be involved in something, you just have to be intentional about it and passionate about it.
People tell you just have to put it out into the universe, right? You would never assume a reconstructive urologist would want to do chronic orcalgia. If you make it known and you go cold emailing people, that's what you're interested in, who knows what will happen.
Yeah, and you're definitely right. I mean, and like I said, I feel that a lot of times with Fournier's is if you like something and it happens to your yum is everyone else's yuck, the work just finds you.
Yeah, and the speaking opportunities too, because there's only so many people who are knowledgeable on that subject.
Yeah, and one thing that I would like to touch on as we kind of talk about there is maybe a smaller community of folks who are really plugged in and passionate to this research that you're describing. But it's funny because I feel like the topic itself is so broad, and the guideline was so broad. I'd love to get a sense of how the committee decided on what it was going to include and kind of where it was going to draw the boundaries.
Yeah, so that's a tough one. I think firstly, part and parcel is to discuss who the committee was, who the players were, and the different perspectives we have. So I know we were going to touch on that. So I'm gonna jump in and add your other questions.
Absolutely.
So, I think one of the things the AUA did so well was compiling this group of people from disparate backgrounds that would weigh in. So, Dr. Lai, incredibly versed in research and IC and CPPS. Same for Dr. Ponteri. So we had a lot of people from the MAP group, like Dr. Clements. And then we had myself and Dane Johnson, who are on the male orcalgia side, and he's andrology trained. Cjo Pericottle, of course, is in private practice, but has done some of the sentinel, landmark research in chronic orcalgia. And then we had a physical therapist, Beth Shelley, who has her doctorate in physical therapy, a patient advocate, Jill Osborne, who did the Interstitial Cystitis Network, president and founder. Larissa Bressler is, female pelvic medicine as well, but she is a board-certified acupuncturist and resiliency coach. So that also adds another layer, which is so interesting. So we have people who treat men, people who treat women, like the holistic view of things, but also the very evidence-based medicine side of things. So I love that we came at it from all of those angles. And it led to some really heated discussions as to what we should include. Obviously, we wanted to touch on pelvic pain and focus on that, but it overlaps a little bit with the IC guidelines because bladder pain syndrome and how to differentiate those two. And then pain syndromes, chronic pain syndromes can cluster. And then also voiding dysfunction, overactive bladder is a feature of CPPS. Like all of the questionnaires feature a subdomain that include voiding dysfunction. It was really tough. We ballooned up to, I'm not really sure, but at one point 70 or 80 statements, I feel like, and then, got it back down to 50 or 60. And to be honest, I don't even remember what the exact count is, but it's a lot. Some of them were just more broad statements, like the not giving repeated course of antibiotics rather than really focal treatment statements.
Gotcha. Yeah, and the broadness certainly stood out to me. I mean, going over, I'm studying for my oral boards right now, so like living in the guidelines and going through that guideline, you guys really kind of came at it. Holistic view I think is the way to look at it. There were just a lot of potential kind of evaluation and treatment options. And I'm sure, when you put all these people together who like have such an expertise, but also come at it from different perspectives, I'm sure you had some like strong feelings on how exactly it should have been done.
Well, so I'd like to give an example and just say something like, okay, you should refer your patient who has chronic pain to cognitive behavioral therapy or, a psychiatrist potentially. That's such a broad point, and you could think about leaving it out from a urologic guideline because it's psych. But if you do not address the underlying stressors that people have, it's a little bit like, we all learn in pediatric urology that you shouldn't do a reimplant without addressing the bladder bowel dysfunction because the success rate of that procedure will go down dramatically. Similarly, I think just throwing pharmacology and surgery at patients with chronic pain is really missing the boat. You have to address stress, support system, psychosocial, the psychiatric component, and coping.
And frankly, like that's why sometimes like this disease process can be difficult, is because not every urologist, has a go-to like CBT referral location, right? Like, I feel like a lot of urologists who are taking care of some of these disease processes, know that is important, know it's important to address the psychosocial, but might not know exactly how or when to pull the trigger on that. And I feel like that's really what made the guidelines such a resource for folks.
Well, here's the thing. To answer that, I agree. Obviously, for instance, as an implanter, I'm going to have someone who can vet my patients from a cardiac perspective. Like ED and cardiovascular disease go so hand in hand. But you wouldn't necessarily think, okay, psych is going to be, I'm going to have a psych person at my ready or a counselor, right? A licensed clinical social worker. But the thing is, it behooves you to have someone in every avenue outside your silo. So I have an orthopedic person I can refer to, a neurosurgeon I can refer to. I do have a counseling. Now I made friends with, a sex therapist practice. These are really wonderful multimodal aspects of care from a couple of perspectives. One, it really helps your patients. Two, it helps you network in the community, and it's bi-directional. So you can build their practice and they can build your practice. Three, you learn from each other. And then, four, you just never know what opportunities will come your way when you link arms and work together, a la how I got on the guidelines panel, right? So it always behooves you to learn from other smart people. And let me just say, the guidelines panel was one of the most academically enriching things of my entire career. I was told not to do committee work repeatedly, and I just want to dispel, not all committee work is bad, guys. Join a guidelines panel. It's great.
Yeah. I mean, I have also been kind of given the advice at times that, you don't do things that like don't have a credit associated to it in some form or fashion. And I mean, I think if something like, it seems like this really fills your cup, and regardless of, whether, this turns, or I mean, obviously being on a guidelines panel is like incredibly important for things like promotion and that kind of thing, but maybe a different, avenue of spending your time on something academic that may not necessarily have that kind of impact. If it fills your cup, I think you do it anyway.
That too. Absolutely. Whatever brings you joy in life.
Absolutely. So given, we've touched upon how broad these guidelines are, I think it would be helpful to break them down a little bit and kind of understand from an insider's perspective, things like tips and tricks are, or places that should really be emphasized for the folks who are utilizing these guidelines every day. So for the initial evaluation, there are a number of domains to consider, from like the typical stuff that we treat, lower urinary tract symptoms, sexual dysfunction, to, as we talked about, musculoskeletal, neurologic, psychiatric. What are your tips and tricks for the initial evaluation? And maybe are there things that were like, as you guys were talking about the guidelines, are there things that are like must hits and things that maybe were debated?
Let's start with the evaluation, the initial evaluation, and how to do that. So firstly, I'll say I've always kind of wanted to write a paint by numbers how-to for when a chronic pain patient comes to your office, because I think the guidelines are wonderful, but it's not a how-to guide. It's on how to apply them. So when a patient comes to your office in chronic pain, keep in mind they've probably waited 60 to 90 days to see you. They've probably seen 3 to 5 providers before you. They're already angry. They've already been in pain for quite some time. So kid gloves, be as nice as you can. And really, if they seem skeptical, if they seem like they don't have a lot of buy-in, if they seem angry, consider how you would feel if you woke up in chronic pain every day. And literally, everyone in the known universe does not want to see them and does not want to help them. We just established that. That's what we just said. So you can understand where they're feeling a little slighted. When I send residents in to see patients who are in chronic pain and have pelvic floor dysfunction, they typically come out with a sheet that is just, there's like this complaint. There's 7 complaints and there's arrows and then this happens. The chronology is terrible and they don't know how, even the most skilled resident does not know how to boil that down into a 2-minute presentation. So what I would say is, the first key tip I can give you is counter to medical training. Do not ask open-ended questions. Do not give them like the floor to tell them everything that's wrong with them. And that's not to say that I think listening is important. You must listen, you must validate. That is all very important. Don't cut them off, build rapport. But I think you have some specific questions you need to get to. And if your clinic is built to do questionnaires, great. Get questionnaires, and you could use something like the NIH Chronic Prostatitis Index or the Koch, the Chronic Orcalgia Symptom Index, something that is fairly comprehensive so that you can get those answers. Otherwise, you start with like, tell me where your pain is. Do you have pain every day? Give me a score. What's the range? Because they don't know how to answer because it's an average, right? So what's the range? On an average day, what is it? What is it when it's low? And what is it when it's high? What makes your pain rev? What are the inciting events? And that's because that can tell you what's going on with them. If there's a particular inciting thing, it might give you a diagnostic hint. And then, what have you tried so far? And it will be a laundry list of things, primarily composed of antibiotics. And then you can just cross all that off your list. Don't do all that stuff again. And so that's how I get to the beginning. The second component is you have to ask every patient, urinary symptoms, bowel symptoms, sexual symptoms, and then do they have any concomitant diagnoses? And you're trying to get it psych there, like anxiety, depression, psych. But I that one I leave open-ended for them to disclose. And last but not least, I say, is there anything I say it's really common for patients to have a history of perhaps some kind of trauma in their past, right? And that could be, it could be something like a really unhealthy childhood. It could be financial stress. It could be sexual abuse. I always put that towards the end of my list. And what I'm trying to get at is, there is a really high concordance with prior trauma and these pain syndromes. And not everyone has that story, but sometimes I just get my spidey sense tingles in the room and I have a feeling. And if you just gently open the door, then you have to let the patient walk through it. So again, trauma-informed care. If they do not trust you and want to disclose in that visit, they're not going to. But if you can establish rapport with that patient and they know you're interested, you can really get a lot established in the first visit. I view the first visit as trust building more than anything else.
Yeah. And I like the kind of mix of closed off or closed ended.
Closed-ended versus open-ended.
Closed-ended versus open-ended. Yeah. Because I have absolutely been that resident. I've also been that attending where I, have a history and I'm like, man, I don't know what happened. I have a lot of information and I don't really know where to put it all. And with some of these patients who do have a very long story and a very long history, I do feel like I really like that advice of you close-ended what you need to close-end and you open-end what you need to open-end, which is definitely not something that I think is like in vogue for teaching, medical students and residents right now, but it can be incredibly important for some folks.
If you don't, you will run an hour behind like me in my first 3 to 4 years.
Yeah.
So I'm just trying to let people learn from my mistakes.
Yeah. Well, I appreciate it. I am in my second year right now, and I am absolutely in that hour behind.
Yep. It'll get better.
Are there musts for like your history and physical, and are there like definite don'ts? So you talked about a little bit about trauma-informed care and kind of opening the door, but you have to let the patient walk through it. That seems to me like you're kind of bordering on a don't, you can't force the answers to questions.
Issue. You also can't force the issue of psychiatric diagnoses. So for instance, there are patients in my office who are nearly hyperventilating and are fidgeting to the point that they're so uncomfortable and anxious just sitting there. And that if I ask them very gently if they have a history, if they've ever been to a counselor or taken medications, for instance, for depression or anxiety, they'll be like, nope. And you know what you know, but you have to just leave it at that. And maybe they've never been diagnosed and you read that on them. In that case, again, your role there is to build trust with them and to say, did you know, I notice your body language says this. You look to me like, you feel uncomfortable. But again, I don't do that in the first visit. You have to help them to gain their trust. Visit 1. Hopefully we do some interventions in that visit that make a dent. If I can just get them a little bit better, even 25% better, then they know that I know what I'm doing potentially. Although usually I'm saying things that are very counter to everything they've ever heard. So that's another key point here is one of the biggest facets of the first visit is you are going to roll back what everyone else has said. And do you know what everyone else has said? George, come on, what have they told these patients that have chronic pain? What do they have?
I think that a lot of them are recurrent infections. I think a lot of them are you don't have, I can't find anything wrong with you. There's nothing wrong here.
Right.
Those are probably the biggest two.
Epididymal orchitis or prostatitis, they've all been told they have an infection. And I'm the first person to say, no, it's not infectious. And we're going to work on your, how you poop. And then they're just absolutely mystified. Or they've been invalidated that their pain isn't real or, no one can find anything wrong with them. And the other thing is the only way to have a happy patient is to figure out what they want and to give it to them. Yeah. So interestingly, some patients come for a fix. Some patients need an answer. It's not enough for them just to get a fix. You can fix their pain, but they still won't be happy. So my favorite analogy, I love analogies. My mother was an English teacher and my dad owned a mechanic shop. So I use car analogies a lot. And I say, okay, so we don't have a study for your chronic pain. If your car doesn't start and I pop the hood and I take a picture, can you tell me why it doesn't start? No, not unless it's really obvious, like the battery terminal is not hooked up, right?
Yeah.
But here's the thing. It could be your spark plug. It could be your alternator. It could be so many things. But a picture won't tell you. An MRI is a picture. A CAT scan is a picture. An ultrasound is a picture. We do not have a functional assay for pain. Your pain is real. I know you feel it. I know it's there, but I can't feel it. I can't prove it. I can't, even see why. I was like, and then in the same breath, I say, I'm going to get a testicular ultrasound. It's going to be completely normal. In 9 years of getting testicular ultrasounds, I've never found any pathology, but that's what we're going to do. We're going to get that picture if it hasn't already been done. But that's just to rule out pathology and do due diligence. But you have to understand that most of your patients come to you with this idea of the Star Trek tricorder that I can just magically wave over their body and deduce what is causing their chronic pain. So we start each visit with, I don't know why you have chronic pain. I don't know why it started. I am not going to be able to figure that out. And furthermore, I might not even be able to fix it. I like to set the bar
Yeah.
really, really low. I don't even disclose that I'm, semi-expert at this level. I say, I can't do any of this for you. And I say, but no one can, right? No one can do those things. And here's why. I say, but we are going to throw pasta at the wall and see what sticks. I have a lot of tricks up my sleeve that you've never heard of from these other providers. And we're just going to try them systematically. And you're going to tell me which ones you're willing to try. And we'll try them. We'll see if you get better. It's that simple.
Yeah, I think understanding the approach is really, really important for patients with chronic pain too. I mean, you're right, like understanding the why and also understanding like the fact that a lot of people are not going to be able to tell them why. You might not be able to tell them why, but you've at least got kind of, if nothing else, you've got an algorithm as to kind of what you're going to bring to it. I had a patient just recently who, we were talking about his neurogenic bladder, and I'd seen him a couple times, and we had kind of gone through the whole evaluation and gone through urodynamics, and I finally sat down with him, and I started with, and it wasn't even intentional, but I started with, to be totally honest with you, I don't know why your bladder isn't working like it should. I don't have a great reason for it. And it was the first time where I feel like I connected with him, and he said, thank you so much for saying that, because, I've been waiting for an answer from a bunch of people, and a bunch of people have tried to give me an answer, and at least you said you just don't know, and that's okay. And it was almost like he was counseling me a little bit. And I'm sure these chronic orchidology people are feeling the same when you tell them, like, look, we may not find an answer for this, but I know that you have it. I know that it's a problem. I know that you're in pain. I'm not going to tell you that you're not in pain because my ultrasound is negative, and I will still work on it. I'm sure that's super powerful for them.
Yeah, I say, here's the thing. I'm not going to give up on you. I'm where the buck stops. Like, I'm not going to refer you away. And if I do, I'm asking a question. Like, I still view myself as the quarterback. I might send you to physical therapy. I might send you to a sex therapist or to, a counselor. But I still view myself as the quarterback who has been tasked with the game of solving your pain.
Yeah. As you're kind of starting the evaluation, and even when you're telling these folks, I don't have a great answer, when are you comfortable making that diagnosis of chronic pelvic pain syndrome? I know that's like the hard question, right? Like diagnosis of exclusion, and in many cases, when do you ever put a name on it?
I was just going to say, I'm going to crack a joke and say, I don't know if I've ever diagnosed CPPS. Yeah. I have a lot of CPPS patients, but I don't know if I've diagnosed them. So I run the visits like thinking out loud. We're getting a little past the point, I'm sorry to say, for Hugh Laurie, of House being relevant. Yeah. But I always bring up House and I say, like, did you ever see that show? You know how they bring out a whiteboard? That is a differential diagnosis. And that is what we do. We think of all the things it could be, and we go through the symptom complex, the history you tell me and the evidence I have, and we cross things off. And so then I talk through my thinking. And just like you elucidated in the last minute with your story about neurogenic bladder, that kind of transparency and honesty is so refreshing to patients who haven't been giving an answer and are so deeply frustrated. And I say, here's why I know it's not your varicocele. So the number one thing that also happens is people get a testicular ultrasound and they get really fixated on varicocele, hydrocele, spermatocele, adocele. It's some kind of seal.
Tiny little cysts.
Right.
Yeah.
So my favorite phrase is I say, oh my God, I have freckles. Do you see them? They're all over my body. And then I say, okay, yeah, that's your varicocele. That's your hydrocele. That's your spermatocele. Like, it is a completely benign finding that, yes, we do see, and no, we don't care about. And then cross. Now, I would like to put a caveat that varicoceles do actually cause scrotal pain, and I'm not that cavalier. That was just for, the effect of storytelling.
Yeah,
but
absolutely.
A lot of times these are like grade 0, grade 1 varicoceles that are not causing 8 out of 10 chronic pain. You know what I'm saying?
Yeah, they're true incidental
Correct. There are incidentalomas. So that's one thing I go through and say with them. So once we've established that those benign things are not an issue, I tell them, these are, here's the whiteboard and here's my 3 leading things. And I rule things out for them that, gives them a sense of understanding and a partnership. And then I say, okay, is that clear? Do you have any questions? I stop after each one, I cross off. And then I say, okay, here's my 3 leading contenders. And it's always like pelvic floor dysfunction, chronic orcalgia, and CPPS. And we go through which ones I think and why. And I give them a lead and I say, okay, we're going to go down this path and we're going to try this. And some of the things we do are not just therapeutic, they're diagnostic. I say, if this works for you, like if you take Miralax and your chronic scrotal pain gets better, I do not think you have idiopathic chronic orcalgia. You know what I mean?
Yeah.
I explain that to them, that some of the things I'm doing is going to lead me down the diagnostic path. And it is an ever-changing landscape. So when they come back to me with more information, we tweak what we're thinking. And I just go through it with them.
Yeah. One thing that I think I hear patients ask a lot for, lots of the things that I do is like, what's the success rate? And what's the recurrence rate? When you're doing kind of a differential diagnosis and you're working through it with them kind of in real time, what do you tell them about success rates? Do they ask about it?
They don't usually ask about success rates as regards most of the pharmacologic therapies or sort of acupuncture or physical therapy type interventions. Sometimes they ask me, do you really think this will make it better? The answer varies. Sometimes the answer is, I don't know, but no one else suggested it and you've tried a lot of things and you're not better. So what do you have to lose? So for instance, when patients get mad at me for suggesting Miralax for scrotal pain, I say, well, I'm the first one to come up with an alternate diagnosis you haven't heard. And I get that you think I'm full of it. But if you buy this $9 bottle of Miralax and it works and all you have to do is drink a beverage once a day, what have you got to lose trying it? $9 and maybe your chronic pain will get better, right? I said, do you want to get better? Then try it. That's my mean voice. So
it's a nice mean voice.
I have a real one, I promise. I am a surgeon. So that's one aspect. And then there are other times that I say, this works, and it works like a charm. So for instance, I use Cymbalta or duloxetine off-label for chronic orcalgia, and fingers crossed, I submitted it to the AUA. I did it. I was having a conversation with an anesthesiologist operating one day and telling her how all of my patients on gabapentin are too somnolent. So they get dizzy and sleepy, and these 20 to 40-year-olds cannot function, and they are at their peak functioning years, right? So I said, I gotta have something else. What tricks do you have up your sleeve? And she said, oh, we use Cymbalta commonly. So this is a great example where it is so beneficial to go outside your silo and look at what other people are doing in other fields. So I read the anesthesia chronic pain literature on Cymbalta, and it was pretty convincing. So then I started giving the same doses to my patients. Now, the reason why people are reticent to do that is there's a black box warning about increased suicidality. And obviously, the younger the patient, the more worrisome, right? But I can tell you anecdotally, I've been doing it for 3 years now. I counsel everyone on that possible issue, and it has helped a lot of people, and it does make a dent in their pain scores, and the side effect profile is really low. So I'm, here's hoping to get that manuscript out so that we can start making that part of it and do a prospective randomized trial, because that's what we really need. But, that's an example where I say, here's this thing, and it's not published, it's not written about, but I really do think you have really good odds of this helping you.
Yeah, absolutely. It's good to know that that's out there too, because one of the medications I'll use for inpatients, especially for kind of pain that may be concomitant with anxiety, is Xanaflex or tizanidine, because it's a muscle relaxant, but it's a cousin of Precedex. And it works for pain to a certain extent, probably because of the muscle relaxant effects, but it's just got a little bit of anxiolytic that helps a lot. But I'm always afraid to give it as an outpatient, similar to the gabapentin, because it makes people somnolent, and it's also a cousin of clonidine, so it can drop people's blood pressure, which I don't like to be in charge of as a urologist.
You know what? You should, though, because Mike Ponteri, again, mentor and co-chair of the panel, he thinks we should put, I don't want to say he thinks we should put tizanidine in the water, but that is his go-to medication. And he has been counseling me on that. So you're on the right track. I have just picked that up this year probably and been trying it. I had previously used baclofen suppositories, which I picked up from my FPMRS colleagues.
Yeah, no, it's a great medication. I'd love to, after you've used it for a little bit, love to kind of hear what your experience is. I start super low with it because that I'm always afraid of that blood pressure. But at least in inpatients, it does great for that person who's like in pain and also afraid of becoming in pain, like afraid of having a spasm of pain. I think it helps a lot.
Can we use that moment to talk about central sensitization and what that is?
Yeah,
because I
please.
think that's so key here. One of the things that is immediately off-putting to providers is that these patients seem tightly wound, and it's because if anything is really painful to you or triggering physically, then when it's going to happen again, and you anticipate that. And that anticipation is part and parcel. And it's not just anxiety. They actually show definable changes in people's sensory motor connections and gray matter with chronic pain syndrome. So again, going back to the MAP network, it's very similar to the patients who have fibromyalgia, and that's referenced in the guidelines. So this idea of central sensitization, the way I explain it is it's, Stewie on Family Guy goes, mommy, mama, mommy, mommy, mama, mama, mama. So then if that was happening to you, then the second your child walks through the door, your free time is like over. So analogously, these patients are sensitized, and what typically would register for you or me as maybe a 2 or 3 registers for them as a 5 or a 7. It fundamentally changes their neural connections and their brain matter to register it at higher levels, and add to that the anxiety they feel over the fact that they know pain is going to come their way.
Mm-hmm. Yeah, I mean, it's crippling. And you see those patients who it's almost hard to relate sometimes because you're like, I just feel like this physical, like the tightness of your shorts can't possibly, be a 7 or an 8. But for some people it is, and they're afraid of it.
Yeah. No, I will tell you that the best way to have empathy instead of sympathy is to walk a mile in the patient's shoes. I would never wish being a chronic pain patient on anyone. And again, I think it's my Mother Teresa capacities as much as my intellectual curiosity that got me into this. Mm-hmm. No one was helping these people, and nothing was written about it. And I am a persistent lady. I do not like when I cannot solve a puzzle. So I just kept digging. But I will tell you, I got a cancer diagnosis about 18 months ago, and there are days that I just wake up completely incapacitated from the beginning of the day. And it really changes your quality of life. It's very difficult to maintain a positive attitude and good mental health when you wake up and first thing in the morning, what you feel is pain.
Yeah, I mean, I can't imagine. It just must make it so frustrating, especially when you're telling people, like kind of circling back to where we started, most of these patients are telling you exactly what they're feeling.
Yep.
And everyone's like, ultrasound looks normal, don't know what to tell you.
Yes.
And it's just got to be crippling, truly.
So along those lines, I never wanted to be famous for any reason whatsoever. I actually really like anonymity because whenever I think about putting myself out there, I think of people like, Taylor Swift and Selena Gomez and all of the haters on their Instagram feed. And I just don't want that. But my cancer diagnosis has emboldened me because I think about how uniquely suited I am to give these patients waking up in pain every day answers and an opportunity to at least find the people who are solving it and who are working on it. They might not get their fix, but if they know who to find, that's just as important as knowing that these guidelines are out there. And so that is why I'm doing this podcast and so many others. I am just going to talk about CPPS and chronic orcalgia till I have no breath left so that the patients can know what to do.
Yeah, well, I appreciate it very much and I appreciate, your work and the AUA's effort to put out the guideline because, it's one of those disease processes that you're right. There were a lot of little bits and pieces here and there in the literature, but there was no real playbook, no real big defined playbook. And even if you're like reading the textbook, no playbook, I think, for a lot of these patients. And I think it's a disease process that's frustrating sometimes when you want to help and you see these patients in pain.
It's frustrating for everyone. It's frustrating for the provider as much as it is for the patient. except that we don't have the pain, right? So let's go systematically. Can we talk about the history and physical? We did the history. Can we do the physical?
Yeah, please.
So I think the most important point here is the 360 DRE. So let me ask, do you do a 360 DRE in your practice?
To be honest with you, I don't have a ton of these patients, but when I do, I read this guideline and I immediately thought to myself, I need to be doing a better physical exam of the pelvic floor because I don't hit a lot of these points.
I would give you credit if you do anything other than the prostate. I'm just so thrilled if you will just swing your finger laterally, guys, one way or another, and like press to the right, press to the left. That's all I'm personally asking out of you, right? Baby steps. But if you press laterally, you're going to hit those levators and the obturator internus. And, if we use the hypothenar eminence to teach people how a prostate should feel, analogously, if you use your bicep tendon, if you feel something tight like that when you go lateral and or the patient says, ow, and it's amazing how many of them say ow, then you have just correctly assessed the pelvic floor. They have tight pelvic floor muscles. Now, here's the thing that no one tells you that's not in the guidelines. When you refer them to pelvic floor, I reviewed my data, my personal data from early practice, less than half will go. So less than half of them are going to go. And why? Because it's young men who you're signing up for a bunch of rectal exams, firstly, not the most fun. Like, would you sign up for that? I wouldn't sign up for that. Secondly, many of them are going to have to drive long distances to the epicenter that has a physical therapist. So, and we know it has to be a pelvic floor physical therapist, because if you just send them to like a regular physical therapist, sometimes I ask when they just pick somebody in the community that's closer to them, I say, what do they have you do? And if they're having them Kegel, that is the wrong answer. So, it's tough to find people in the community that do it too. So the thing is, you got to assess that pelvic floor. It's so key. So if there's nothing else you do on physical exam, please just assess the pelvic floor and ask if they have pain. Now, you want to do a neuro exam concisely if they have any tingling. And I think it's really important, if you think about this, one of the first things in your head should be, is their pain focal or is it systemic? If they have pain in their suprapubic area or their perineum in addition to their testicle, it is not orcalgia. Do not operate on their testicle or the surrounding structures. I would not, in that case, zero in on a denervation off the bat, right? You need to be thinking more of a systemic neuropathic type pain. Whereas if it's just just one testicle, or it can sometimes just be both, as long as they don't have voiding symptoms or bowel dysfunction, etc., that's fine. The other thing is painful ejaculation as a symptom. If people tell you they have that, they have one of two things. They have a urethral stricture, which is an anatomic obstruction because of scar tissue, or they have pelvic floor dysfunction because it's a functional obstruction. They are ejaculating against a closed stricture, which feels equally as painful, but has a different underlying mechanism.
Yeah, no, that's super helpful. And I don't do the perfect 360 DRE, but I have definitely, when you feel those tight pelvic floor muscles laterally and you say, oh man, there's a bowstring in there. But you're right, it can be frustrating when it is difficult to connect patients with pelvic floor physical therapists specifically, who kind of, know their way around, the visceral pain that people are getting in those muscles. That's
okay though. For every challenge, it is an opportunity for improvement in medicine, right? That just is an opportunity. So right now, my workaround is I use the other forward patient-facing people on YouTube. So Stephanie Pendergast and the Pelvic Health Rehabilitation Center has some great videos. And I literally have QR codes on my phone that I just hold up and let the patient, I say, here, go look at these at home.
Oh, nice.
You can also find other ones that will have home exercises and then just add them. And you can link them by text if you have an app like VidScript, or you could curate that with Well Prepped, Dr. Kane's, anything. But you could use videos and home exercises without going to a pelvic floor physical therapist when you have these healthcare deserts, right?
Yeah, which there's I talk all the time about the shortage of urologists, but the shortage of pelvic floor physical therapists, I'm sure, is more.
Yeah, but we can always, there's a workaround. We can get this done.
Now, we've talked a little bit about pharmacologic management, but what about your non-pharmacologic medical management? So not the people who you say, like a denervation is the thing for you, but things like pelvic floor physical therapy we've talked about. What about things like acupuncture? Talked about counseling a little bit. Could you go into the non-pharmacologic?
Yeah, so acupuncture, really you should interview Dr. Bressler, the board-certified acupuncturist. She is just phenomenal wealth of information. I was really not familiar with the data or acupuncture itself. I just had acupuncture last year for the first time as part of cancer care. And I started reading the data, and it is really deeply fascinating. It has been around for 2,000 years. It improves quality of life scores, the pain scores, and the voiding symptoms. That is just like mind-boggling to me. So the thing is, I referred to acupuncture. I found out we had an acupuncturist here. So firstly, find out if your academic institution has one. If you're in private practice, I'm sure there's somebody, private practice you can refer to. So I think, why not? I use that a little further down the algorithm as once we've built trust, like, hey, try this. Other things, I think the data on shockwave lithotripsy is just so fascinating. I really want to try that out and do a trial in the US. So if anyone in the shockwave industry is listening and wants to gift me money to do that, I would love to. Mostly comes from other countries, but there was a meta-analysis of small trials, like 30 to 60 patients, but pretty well done. And even despite the fact that they delivered the shocks different ways, it was about 3,000 shocks and usually done over 4 weeks, it does reliably improve quality of life and pain scores reliably across the board, which is just so fascinating to me because, we don't understand the mechanism. Urologists are a bit like a hammer and everything's a nail as it comes to the shockwave machine. We'll try anything with shockwave. So that's acupuncture and shockwave. Was there anything else in specific you wanted to ask about?
Well, I was going to ask about mechanism, and you kind of answered it. Have there been theories on why that shockwave is effective? Is it like neuromodulation or? The
ones I heard for Peyronie's were something like stimulating VEGF and angiogenesis. So maybe that was for low intensity shockwave and ED. I don't know if anything has been suggested as regards to like pain in Peyronie's disease because, again, going back to the guidelines, you can give that to mitigate pain for Peyronie's disease.
Yeah. One more kind of non-pharmacologic, and this is my own, at least I think my own kind of approach to it. And I learned it with one of our pediatric urologists in training at Vanderbilt. His name is Doug Clayton, and he used to have patients read this book, and I think it's called As Supple as a Leopard or Becoming a Supple Leopard or something, but it's about stretching like your skeletal muscle, not necessarily pelvic floor physical therapy, with the idea that your spermatic cords course through a potentially very tight muscular canal in the inguinal canal. And I have had people like start on stretching routines. I feel like it's always tall runners. You start on stretching routines for orcalgia and see some improvement. Have you ever encountered anything like that?
So there's no data to the best of my knowledge on that, although, there's probably data somewhere. I have had patients tell me that stretching improves their pain, which to me is always kind of diagnostic of pelvic floor dysfunction a little bit, because the way I think about it is I show them a Netter's diagram of the pelvic floor and say, do you see these holes? This is where your spermatic cord goes through. And if you think about all of these muscles being tight, they're probably being squeezed. I would also say anecdotally, quite a few of my patients describe a sensation of a really uncomfortable lifting, which I assume is their cremasterics being activated, and this pulling sensation. It could be their pelvic floor versus their cremasterics. I'm not sure, but I will tell you that probably as many as 100 patients have told me that same story, and it's not written about in the symptoms or the textbook. I've never heard it from another person, but patients tell me that over and over again. So yeah, I do think stretching is really valuable. And I tell patients to go try that at home. Another thing is phytotherapeutics were mentioned in the guidelines, and those are, pollen extract, quercetin, etc. So those are kind of last ditch. But I also have patients who have mentioned freeze-dried aloe to me. Any kind of supplements you want to counsel that, it's not FDA regulated, etc. We don't really know about dosing, and these are really small studies. But I think we should be exploring those options. I think we should be listening to our patients when they say, hey, this helps.
Yeah, absolutely. And maybe, if the evidence isn't there, creating it.
Yeah, exactly. Feel free to, donate to my GoFundMe. I'm kidding. I don't really have one.
Having talked about a bunch of different ways to approach treating some of these pain problems, when do you follow up with these patients? How often? Because I do feel like, it runs the gambit of this thing, that we're prescribing should work on the quicker side. And I do feel like patients in pain want to follow up very quickly to get on to the next thing if it's not going to work. And sometimes I find myself saying, I know you want to follow up with me at this time point, but I need you to give it a little bit more time to kick in. Should we follow up a little bit further out? So do you have a pathway or a normal kind of cadence?
So I think we should acknowledge the elephant in the room, which is we are all overworked and overloaded, right?
Yeah.
What you're indirectly alluding to is the fact that when you look at your clinic schedule in 2 weeks and you prescribe, let's say, Flomax, and it's going to take effect in 24 to 48 hours, you don't have a slot in sight in 2 weeks.
Yeah.
So here's the thing. Yes, pain patients want to be seen as much as possible, as fast as possible, because they want to try everything. And you don't have the bandwidth to do that. I try to give them multiple things to do in every visit. So the first visit, I treat like a trust building exercise and a shotgun visit. So let's say they're a pelvic floor dysfunction patient. I say, this is counter to everything they teach us in medicine. In medicine, they teach us 7th grade science, fair science, which is one variable, measure the effect, then, yeah, exactly.
Yeah.
But if you do it that way, it's infuriating for the patient. Put yourself in the patient's shoes. So I say, okay, I'm not going to do that. I am going to throw a bunch of stuff at you to make you better as fast as possible. And you're going to tell me what you notice works. And so I say, take a hot bath for 20 minutes at night, assuming they're not actively trying to impregnate someone, because you have to counsel on sperm counts, right? So 20 minutes a night, steeping hot in the bathtub, that'll relax your whole pelvic floor and get you some good sleep. And we know how sleep is so important for cognition.
Everything.
Yeah, everything, basically.
Yeah.
Cognition, mental health, depression, anxiety, how you're going to register the pain, etc. So I try to get them that. I say, take this Flomax and see if it improves your pain symptoms or your urinary symptoms. And I say, also do, 2 weeks of NSAIDs, morning and evening. Just do it to break the pain cycle to decrease the inflammation. So I shotgun that first visit, and that gives them a lot to do. And then usually it makes a little bit of a dent. And then on the second visit, I start sequencing. Now, your question, when is that second visit? I try to go a month. I try to give them a month to give them enough time to try it, not enough time to just give up. I also ask them to write down, specific information, because we're so bad at, and including me, you're so bad at knowing what feels bad. You really only register when you feel bad and you get better, what made that transition point, or when you're well and you get worse. You register those two transition points. You don't actually register. Very few people are mindful and wake up and do what I do now as a cancer patient, and you ask, how is my body feeling? What do I feel today? Where do I feel any discomfort? What should I do about that? That is not how we live. And in fact, we have done 5- and 6-year residencies that have pathologically taught to avoid
push it out.
Don't eat, don't sleep, don't pee. You don't need any of that. You don't need mental health. You don't need to see your family. Just operate, right? No offense to the medical community, all of us as a whole. So the thing is, I ask them to be really mindful. And I say, I want you to take notes. And I want you, in your handy dandy little device in your pocket, you can take some notes, right? So that's one thing I ask them to do. And then they come back to me, and usually they give me sort of some information that's guiding. And then that next visit, it depends on what we're doing. If we're doing a spermatic cord block, I give them a month or so in between, because I ask them to take pain scores. And really, I say 3 times a day, I want you to stop what you're doing and write down a pain score. What do you feel? And it shows me with numbers how long that block lasts. Incidentally, to people who are not doing this, it's the same block you give for a vasectomy. It's so easy. And when you give it, it's designed to be temporary, but I will tell you, overall, my patients will tell me 2 and 3 weeks. Like their numbers don't lie. It shows me 2 to 3 weeks of pain relief. So I don't like to give repeated cord blocks as a therapeutic option. It's really a dress rehearsal for a denervation for me. But I give 2, and the first one is proof of principle, and the second one I say, okay, now go do whatever makes you hurt, have sex, run with your pack on for my military guys, like do all your training and see what happens. If it's a pharmacologic therapy, I try to give it about a month too. If it's something more involved where it's going to involve a referral, like let's say we're referring them to someone, I give 3 months, but I also give them a prescription for something. So I say, okay, you're going to go see anesthesia, chronic pain. I also shotgun that. I say anesthesia, chronic pain. We're going to set you up with a pelvic floor physical therapist. Here's the sex therapist. And here's a prescription for, right? And then at the end of 3 months, we're going over all of those things. We may have a longer visit interval, but we try to get as much done in that visit interval as we can.
Yeah. Gotcha. Okay. That's helpful because I had a kind of an older attending in residency, and I can't remember whether it was for LUTS medications or ED medications, but he used to give what he would call a trial pack, and he would give a 30-day supply of a couple of different formulations and say, go home, see what works for you, and then that's what we'll get you on when you follow up. And I think he, found a lot of success with that.
That's, it's so practical and so useful and so great for the patient. But I can also see the other side where you're opening yourself up to liability because you're giving these multiple medications. And what if they don't take them as prescribed, et cetera, et cetera? I think we all constantly struggle with that.
Mm-hmm. Yeah, I mean, it's tough because, in like today's day and age, everyone practices defensive medicine, even if they try not to or don't want to. And it can, it does put you a little out on a limb to, send someone with multiple medications. But you're right. It's like, man, it seems much more real world practical than a lot of the things that we do where it's like, all right, we're going to try this one thing. You will do nothing else. You will come back to me. We will see if it works.
Sometimes
then we'll try the next thing.
If I give 2 things, I write it in my note and I make it very clear. I say, okay, the patient's going to try Flomax first for this period of time. If that doesn't work, they'll stop it. And then they'll try, like, let's say Cialis. I'm just giving examples, but pharmacology.
Yeah, no, it's a good way to do it. And I can't remember if that person had like a handout or anything to go with it to kind of explain the sequencing, but that can certainly be helpful and probably protect you as well.
I think so it works both ways. So the patient can see it in the portal. So when they go home and they forget, they can look in the portal.
Oh, yeah.
And so I say that to them. I say, sign up for the portal and then you can see this because it's really hard to remember everything your doctor says to you. Again, I think we should have videos for that patients can look at home. But that's like a molehill I'm going to die on. That's another one of my key talking points. But in lieu of that, while I build my cadre of videos, I write down the homework for the patient. I write it in my hand and I also put it in my medical note.
We've danced around it a little bit, but chronic scrotal pain is also addressed, and it's different, obviously, from chronic pelvic pain in the guideline. What are kind of your do's and don'ts for chronic scrotal pain, and what differentiates it as well?
Chronic scrotal pain is chronic scrotal pain, period. Full stop.
Yeah.
Right? So that's how I want people to remember it. When I give this lecture, and I would give this lecture to any residency that wants it. I want to tell so many people about this information. I want to take 10 years of practice and make it so simple for you. So if you see a patient who comes into you with testicular pain, you ask them, how are you peeing? How are you pooping? How are you having sex? If all of those things are fine and they're pain, and you say, where is your pain? And it's just testicle pain, you have a chronic orcalgia patient.
Yeah.
And then to further simplify that, if they've had a vasectomy, if their chronic orcalgia did not stop right after their vasectomy, I do not call it post-vasectomy pain syndrome.
And then you said you typically will like a cord block as you call it a dress rehearsal for a denervation?
Yeah, so that's if I think they're just chronic orcalgia, then I think it comes into play. You have to listen to your patient and their desires. So there's some different flavors. So some people want a definitive fix. Right? They want surgery and they want it to be done and over. Some people are afraid of surgery and don't like the idea of surgery, so they want medication. Some people want medication, but they do not want to take psychiatric medications. The second I tell them it's an off-label psychiatric medication, they are not interested. Some people will go to a counselor and address their issues with coping skills and stress. Some people won't. Because pain, regardless of whether it's pelvic floor or arcalgia, you know that your mental state impacts your pain scores. Yeah, I don't know that I have a one-size-fits-all. I have a worksheet that is a visual algorithm, and I hand it to the patient and go over each and every option. And I say, what about that looks good to you? I register their micro expressions on their face as I present each option, because a lot of times their face will tell you, no, yes, right? And then you say, this, you seem to be really interested in this option. And then you try the options in the sequence that the patient wants to try. And that builds trust, shared decision-making, gives the patient autonomy, control over their own life in a situation where they have felt so deeply frustrated that I think, again, it will make them willing to work with you. You'll get some buy-in, and they might be more willing if you want to steer them towards something that you think could be a better option for them. Now, again, you steer, but they pick. I just want to be clear, like the patient always gets to pick what happens to their body. So if they don't want to do something you think is a good idea for them, tough nooks, come up with a different option.
Yeah. And I mean, in this space where the data is still very much evolving, you kind of get that freedom a little bit, I think. Yeah. Speaking of that, what do you think the priorities for research should be for the future? Chronic pelvic pain, chronic scrotal pain?
Asking Dr. Lai and Dr. Ponteri what the priorities are, since they're the experts. No, so I think we need some funding because chronic pain often gets overlooked because it's not something you can see and you can measure. And it's so nebulous. And it's really, I don't think we're really capturing the full numbers of people who have chronic pain in this country. So I think better assessing our patient population and their needs is a good start, right? And then from there, I think if we put some money behind disseminating this information, the questions will naturally sort of come up. The more people know what the options are and start using them, the more the questions will generate themselves. It's once you do one thing, it generates the next thing, right? So I think we need to better characterize some of our pharmacology, because even though these are options, we don't necessarily have well-done trials for every pharmacologic option against other pharmacologic options, sham or control, et cetera. That's one thing. So for instance, I would love to run a trial for Cymbalta versus a placebo and really measure with the questionnaires. But that is going to require some money to give out that Cymbalta. It's going to require a research coordinator to do those questionnaires because I don't necessarily have time in my clinic to sit there and go over the questionnaires with patients. I also think we need to put funding behind these ignored therapeutic options. So to my very good friend and colleague, Dr. Larissa Bressler, we need some acupuncture studies, We need to find out some really good studies on what pelvic floor physical therapy is capable of, to address Beth Shelley, and shout out to her. We need to get a sense of how many of these patients have other things, like how many of these patients have things we're missing. So my fellowship director, in combination with Amy Perlman, wrote a great article on hip pathology masquerading as testicular pain, which I have also diagnosed. There's also like disc herniations. How often is that? I have no idea. But Dr. Ponteri says he sees it all the time, and I just recognized my first one, possibly from his tutelage, right? So I'm curious, if we take patients who come to you with chronic pain and start to break them down, like how many of them sort out and what's most common? What should we be looking out for? And that's just me spitballing, right? Like, as you know, it is the Wild West, and I would love to do the shockwave therapy too. And then I would love to see why that's working molecularly.
Exactly. Yeah. Thank you so much. This has been such a wonderful discussion. When I saw this guideline, like I said, I was so happy that a playbook was, starting to get developed. And I know that every urologist who listens to this is going to be very thankful that there are urologists out there who are interested in, these disease processes and in kind of taking a leadership role and, helping us figure out how to help patients. I can't thank you enough for taking the time.
I can't thank you enough for giving me the platform to shout it out, because it is so common. I think they say for orchalgists, 5% of office visits, right? We all see it. So all I'm trying to do is make your life simpler by giving you some options for what to do about it.
Yeah, well, we very much appreciate it. Dr. MacDonald, this has been great. If anyone hasn't seen the 2025 guideline, they should absolutely take a look. And again, thank you so much for your time.
Thank you for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.